Medicine here at UCLA and the director of the Ahmanson UCLA Adult Congenital Heart Disease Center, which is one of the largest of its kind in the U.S., serving nearly 4,000 patients a year. Dr. Aboulhosn has extensive mentorship, research, and experience in ACHD, in particular transcatheter congenital and structural procedures. He's currently and has been an investigator on multiple NIH or biotechnology-funded multi-center clinical trials. He's a founding member and previous president of the Adult Research and Congenital Cardiology Network. Furthermore, he's actively involved in the AHA related to the development of clinical practice and care guidelines in the ACHD population, particularly with Fontan-associated liver disease, and has been an ongoing important area of interest to him. He additionally specializes in the management of pregnancy in patients with congenital heart disease and has co-authored numerous manuscripts on this topic, including a scientific statement from the AHA in 2017 on the management of pregnancy in complex congenital heart disease. Dr. Aboulhosn, thank you so much for giving me an answer today. We're also excited to mention it.
Thank you. Thank you. I appreciate everyone who has joined virtually and who's also here in person. You know, usually when I give grand rounds, I talk about, you know, some of the sort of very futuristic things that we're doing in the cath lab, the transcatheter valve repair and replacement procedures, you know, for the cardiographic imaging and things of that sort. But today I decided I'm going to take it back a little bit to some of the basics and talk about the importance of diagnostic catheterization. And I think, you know, the reason I'm doing this is that I'm finding more and more that this is becoming kind of a lost art in cardiology, where folks are either specializing in non-invasive, non-interventional, or interventional, which is intervention, putting stents, replacing valves, ballooning things, etc. But you know, not with a huge focus on the diagnostic aspects of catheterization and how can that can be really important. So I'm going to focus on that today and talk about how we utilize diagnostic catheterization to figure out real conundrums in adult congenital patients. And it's basically going to be a lot of case examples more than anything else, but hopefully for the fellows specifically, this will be somewhat enriching. I do have pertinent disclosures here. I have research grant funding from numerous companies, as well as proctoring and transportation work that I do for various valve and intervention.
Excuse me? Share screen. I don't know.
Oh, am I not sharing my screen? Elia, would you mind sharing my?
Yes, you are.
I can see it.
The people in the room here are not seeing it though. So if there's some way we can change it so that on your screen, which is being.
Are you sharing the PowerPoint from your screen or this?
I'm sharing the PowerPoint from my screen here.
Our view here.
Yeah, it's from your own laptop.
So change the view.
Let's see it.
On my laptop?
No, not you. And then try gallery. Try one.
Hit share. There we go.
Someone else is sharing.
Someone else is sharing.
He is sharing.
I'm sharing my.
He is sharing. He's not using them.
I'm not
Oh,
sharing.
there we go. There we go. Gotcha. We see it. Okay, we're good.
Okay. All right. Awesome. Okay. So let's get going. Here are and then also this is pertinent regarding the adult congenital heart disease board examination. I'm not going to be going over any specific questions, but for the ACHD fellows in the room, and any ACHD fellows that are watching this, pay close attention because a lot of the information that I'm going to go over, there's going to be a lot of questions on the ACHD board exam regarding the hemodynamics that we're going to go over. So I'm going to just go very quickly through the historical perspective here. So the pie charts here tell it all, in that we have an aging population with congenital heart disease. Back in 1965, about 30% of patients were adults, and most of them were young adults with simple type lesions, you know, ASD and maybe a VSD, etc. Patients with complex congenital heart disease. For those of you that are rotating with us in ACHD clinic, Fontans, we're not surviving because there was no Fontan back then, right? We just had single ventricles that mostly died in childhood. But now we are dealing with 70% of the population being adults and about 30% being congenital pediatric patients. And so therefore, we have seen basically the rise of a new field in the latter part of the 20th century. And actually, UCLA had a very important role in the beginning of this new field because of the coming to UCLA of a guy named Joseph Perloff, okay, who's considered the father of the field of adult congenital heart disease. Dr. Perloff came here from Penn, and he was at the NIH in Georgetown before, and he started a clinic that served adult congenital patients specifically. He started it in 1978, and in 1980 formalized the clinic, and thereafter it became a center. He managed to get an endowment from the Ahmanson Foundation, which is why it's known as the Ahmanson UCLA Adult Congenital Heart Disease Center, and it really set the standard. Dr. Perloff's work there in the 1980s and the 1990s, and it wasn't just him, it was Dr. Child, Hillel Lax, who was one of the top surgeons in the world, came to UCLA and became the chief of cardiac surgery here. And really these programs just all took off. And, you know, I need to update my bio because this year we're on track to see 8,000 adult congenital heart patients in the ACHD clinic. So we've doubled our volume even just in the last few years. So it really is a growth industry. And for the fellows, listen, if you want a job and you want to pick your job, you can pretty much do ACHD because a lot of places are looking to hire ACHD specialists. There's a real dearth of ACHD specialists in this country. About 1% of all human beings are born with some form of congenital heart disease. Now, it depends on where you are, though, because if you're in Italy, then that number is higher. Why? Because they actually do echoes on all children that participate in any sports in school. And so, therefore, they're picking up a lot more stuff, right? So, and a lot of that we're talking about are things like, you know, some mild aortic valve pathology, cuspal inequalities, formed use of bicuspid aortic valves, those kinds of things. And it depends on what you include as congenital heart disease. I mean, gosh, if you include hypertrophic cardiomyopathy and you include PFOs and then, you know, 30% of the population has some form of congenital cardiac abnormality. We generally don't include that when we look at our numbers. So we are talking here about, you know, real congenital heart disease. Survival into adulthood, as I said, has become the norm, and hence the population, and this has been the case now for the last few decades, is growing by about 5% per year, okay? So growth industry. Cardiac cath is really still considered the clinical gold standard for assessing cardiovascular hemodynamics. I know, you know, we have great non-invasive imaging. Listen, I love echo, CT, MRI. Anybody that's rotating with us knows this, that we spend a lot of time looking at non-invasive imaging. But in the end, when you really want to figure out what's going on, if your non-invasive imaging is confusing, you're not coming up with the right answer, things don't fit, you still need to know how to actually do a cardiac cath and come up with the right answer that can potentially be gathered by cardiac catheterization. So starting in the 1970s, echocardiography, and really cath started, very first cath was done in the 1930s, right? Werner Frostman catheterized himself, right? That really famous image where put a urinary catheter through his basilic vein into his superior vena cava to the right atrium, ran up or down a few flights of stairs, took an X-ray, and that became the first catheterization, right? But really, cardiac cath, even for diagnostic purposes, didn't really take off until the early 1950s. And it was, if you speak to some of our more experienced colleagues that trained in a much earlier era, really cardiac cath, diagnostic cardiac cath was the way that you diagnose things. You know, physical exam, you did chest x-rays, and then you took him to the cath lab and you measured direct pressures and saturations and did angiography, et cetera, to figure things out. Starting in the 1970s, though, echo with Doppler came on the scene. And pretty quickly, within a decade or so, you saw it begin to supplant diagnostic cardiac catheterization as a non-invasive and now really universally available and generally accurate alternative to hemodynamic catheterization. So there are so many cases where you don't need cath because you've got it figured out by echo, right? And a great example of that is valvular aortic stenosis, okay? Back in my day when I was training, and maybe a few years before Eric, at Harbor UCLA, we used to have AS cases where we would cross the valve and we would do simultaneous pressure recordings in the LV and DAO. And then we would go through and do the Gorlin formula to figure out what the aortic valve area is to confirm the echo finding. Okay, that's now been pretty much a thing. Rarely are you going to the cath lab to confirm that somebody has severe aortic stenosis or not. Rare, but you still need to know how to do it when the other information is confusing or inconclusive. Why do we avoid that now? Well, what you don't want to do is knock off chunks of calcium and little clots and stuff and cause strokes in people and complications in people when by and large you can get the answer non-invasively. And so what we saw is diagnostic cath for many forms of congenital heart disease and structural heart disease as well was no longer needed to make a diagnosis or assess simple hemodynamics. Now you add to that MRI and CT as cross-sectional imaging modalities that can give you 3D volumetrics and multiplanar imaging, functional assessment and stuff. And gosh, we've got Google Earth. Why do you actually need to go and walk that road now, right? By and large, you're able to tell what's going on. However, hemodynamic cath is still necessary in some patients. And here's a few, and this is just my own list, okay? Patients with single ventricle Fontan physiology. Okay, you are not going to know what's going on non-invasively because there's no great non-invasive way in Fontan patients. Tell what the Fontan pressure is and what the single ventricle filling pressure is, and to assess pulmonary arterial resistance, systemic arterial resistance. These are all really key in single ventricle patients. So those we are still doing diagnostic caths in. How about patients with pulmonary hypertension? Okay, well, you'll be able to tell if they have pulmonary hypertension or not non-invasively. But if you want to assess for vasoreactivity, you do vasoreactivity testing. And by and large, now that is still cardiac catheterization that does that. And then lastly, when non-invasive testing is inconclusive or contradictory. So we talked about this. Okay, this is from colleagues of mine that are actually congenital interventionalists as well. Okay, that have said things like this. Why not take the time, or I would say, why not take the time to fully assess hemodynamics if you're in there and doing an intervention, right? And number one answer, it's unnecessary. Who really cares? I already know what's going on from the echo, right? I know there's a big right atrium, a big right ventricle, a big left to right shunt, and an ASD. What do I care to check hemodynamics, right? Let me just go in there, close the ASD. Time's money. I need to generate my RVUs. Let's go. So that's number one. Number two, I don't have the time. We have a bunch of cases related to number one on schedule, And listen, it takes time to figure out shunts and flows and resistances, and you have to actually sit and, it's not just, hey, I can just dictate the report real quick. You have to do some math, or as they say across the pond, some maths. I don't really know how to do it well. We didn't focus on that during my training. And honestly, you guys, the reason I'm giving this grand rounds today is that answer is coming up a lot more, okay? People finishing cardiology fellowship coming out and going, yeah, we just didn't really do much of this at all. I'm fine reading echoes, I'm fine whatever, but I'm just like, the most I did was swans. And then otherwise I was kind of just like hanging around while the interventional fellow was actually doing the actual work. So we just didn't really train. So this is where I'm going to try to give you some resources today as well to help you. Some of this has to be, you're always welcome to come and observe us in the congenital lab, but I think some of this is also stuff that you should read up on a little bit as well. I think it's just part of general cardiology training. And I will just point you in the direction of this article that I'm co-author on, where it's me and basically the folks from the Mayo Clinic. And what we did here, we wrote this, and it's in, I think this is in SIR cardiovascular intervention, maybe JACC cardiovascular intervention. So this is in JACC CV interventions. And what it's about is catheterization in adults with congenital heart disease, and it's a primer for the non-congenital proceduralist, okay? Which means this is not for ACHD specialists that have done a 2-year fellowship in this. It's for general cardiologists and invasive cardiologists. And I'm including this particular figure because this tells you how to calculate shunts, okay? Simple. Go to this paper, download this paper, take this particular figure and or table or whatever you want to call it here, figure, but take it and actually have it somewhere where you can get to it quite easily after you've cathed the patient or after a colleague of yours has cathed the patient and then, said, okay, well, I checked this, whatever, it looks fine. Maybe the interventionalist isn't going to take the time to do it, but you as the cardiologist who sent the patient for the cath can take the time then and look at this and go, okay, let me try to figure out if this patient needs to be on pulmonary vasodilators or not, okay? Whether this patient meets criteria for closure of this ASD or not, okay? It's always good for you to also know how to do it, even if you're a non-interventional cardiologist. And I'm not going to go through the details of how to calculate simple shunts at this point. Please read up on this. This is just part of standard cardiology training. But you can also break it down instead of just an overall QP to QS. What is Q? Q is flow, P is pulmonary, S is systemic, okay? So if you use the above equations, the equations up top, you're going to get a QP to QS ratio. But then you can actually go in and get effective flow, effective pulmonary blood flow and systemic blood flow, and then thereafter end up actually calculating a % left to right and a % right to left shunt. It's very simplistic to think that patients just have just a left to right shunt or just a right to left shunt. That's not how the world works, right? It depends on where you are in the cardiac cycle. For example, an ostium secundum ASD may predominantly shunt left to right, but with the atrial kick may actually shunt right to left. Okay, and so then that person may be at risk for paradoxical embolism, even though they're shunting the vast majority of left to right. And the same thing can happen at the ventricular level. People think of this and they go, oh, restrictive VSD, high velocity left to right shunt in systole. Yeah, but you could be right to left shunting in diastole if the RV diastolic filling pressure exceeds the LV diastolic filling pressure. So this is where you can get more nuanced assessment of just how much shunting you have in each direction. And then this is just a figure here that goes over some of the basic lesions that you might face and where to actually check oxygen saturations in order to figure out systemic blood flow and pulmonary blood flow. Okay, really simple. As you approach a specific case, you go, okay, I have an ASD case, I'm going to cath this patient. Just bring this figure up and figure out, okay, what sats do I actually need to get for that patient? Because very often I will see cases sent to me from outside where somebody went in and did a catheterization and hardly checked any of this. Okay, or check the wrong stuff. So you guys are training at UCLA. I feel it's really imperative. It's my job here to ensure that you please know this. Okay, so here's another figure. It's that same article, easy to download. And then this is also from that same article. What is, sorry, it didn't copy that well, but in order to figure out what is a significant shunt, how much of an oxygen step up do I have to have for this to be significant and where I'm going to do closure of this defect. So if it's an atrial level shunt or anomalous pulmonary veins, we call those pre-tricuspid valve shunts. Okay, the pre-tricuspid valve shunts, you want to see a step up from the SVC, or sometimes it's the anomalous vein, depending on where the anomalous vein comes in potentially. You've got to be before that oxygenated blood comes in. So you've got to go proximal to that, okay, to get this sample. And then you check a pulmonary artery sample, and if the step up is greater than 8%, so let's say I checked a high SVC sat and it was 60%, and then the PA sat is 70%, okay, and there's an anomalous vein coming in, then that's going to be a QP to QS ratio of 1.5 or greater, which is the threshold that we use for deciding when to close shunts. Remember that number for your boards, okay? Greater than or equal to 1.5 to 1. All right. At the ventricular level, we have a lower threshold at 5% or greater. And at the pulmonary artery level, these are things like patent ductus arteriosus, aortopulmonary window, coronary to cameral to PA fistulae, 5% or greater at that point. Okay. Let's now just go to ASDs, right? So ASDs are simple, right? not so much. That's a facetious example. So this is an ostium secundum type ASD. This is the most common one you're going to run into in adult patients. And this is a hole that's going to generally exist in the area of the valves. This picture is a picture that I actually took when I was a fellow down at Harbor. Very sad case of a young lady. She must have been in late teens or early 20s who came in pregnant with severe pulmonary hypertension, ostium secundum ASD, and she basically went into preterm labor, and then unfortunately she bradyed down, coded, we couldn't bring her back, okay? So we had a terrible situation of a stillbirth and a mother that passed, okay? Now, one thing I would recommend that you guys do, which I did in my training, and I've never regretted it, is every time this kind of thing happened, I wanted to go and participate in the necropsy autopsy, okay? You learn a lot. You learn a lot when you do that. And this is just a picture that we took of this lady's ostium secundum ASD. When I'm thinking about ASDs like this, and can I close them or not, I have to think about hemodynamics, but I also have to think about the rims that exist around that hole that can then allow me to put in a device that's going to be stable or not stable. Okay, so what I've done here for you is I've basically colorized the various rims that we think about when we're thinking about, can this be percutaneously closed or not? Okay, and you don't have to have all these rims present. You can have deficient rims, but you can't have multiple deficient rims in multiple areas. So for example, you can be missing your retroaortic rim, but if you're missing your retroaortic rim, you've got to have a good posterior rim. Otherwise, device going to go flying, right? So you can't just hang it on to, you know, two threads and hope that it's going to be stable. So when you're doing your echocardiographic assessment, transthoracic, start with transthoracic. If you see an ASD, you want to comment on the presence of these rims, yes or no. And if you're doing a TEE on an ASD patient, this is where you've got to be very particular about this and actually go in and look at the various cuts and then judge, okay, do I have rims here or not? And what's the length of these rims, okay? And down the line, depending on where you end up taking jobs, et cetera, you may be asked, if you're non-invasive or non-interventional, you may be asked to TEE guide ASD closures, right? And this is where it becomes really key that you know these rims to decide, did this guy put the device or this gal put this device in a stable position? Did they grab the necessary rims, okay? Now you may say, oh, well, you know, isn't the interventionalist supposed to know that? Sometimes yes, sometimes not so much, right? So the more you know as the non-invasive person about this, understand the hemodynamics, understand the anatomy, understand where devices go, what kind of devices we use, et cetera, the better off you will be as a navigator for these procedures to help the patient safely get these procedures. Other types of ASDs. Now, this is a drawing that I did. I don't remember where it ended up, but I think it's in one of the textbooks. Maybe in Hearst, or I think this one ended up in Otto's Echo textbook. But, and I should have probably put a little thing there, but be that as it may, I'm just going to use it anyway. This is looking at the various types of ASDs that you may run into. No one has all of these ASDs, okay? But you should be looking in somebody who has RV enlargement and RA enlargement, unless you have a really good reason why they have that, you want to make sure they don't have one of these volume loading lesions. And so the ostium secundum ASD that I just talked to you about, that one's easy, right? Because that one you're able to see on a 4-chamber view. It's like right there. It's hard to miss, especially for the sizable ASD. However, the superior sinus venosus and the inferior sinus venosus ASDs, you may not see in a 4-chamber view. You may have to go hunting for those. And so that's where, don't just think that there's no volume shunt just because I didn't see it on a transthoracic echo, right? You may have to go and order an MRI or do a TEE. These anomalous venous returns are also difficult to see unless you have a congenitally trained sonographer who's like, you know, Majid's in the room here. He's a pediatric cardiologist. You know what they're much better at, the pediatric cardiologists and the pediatric sonographers? They're very good at looking for these anatomical problems. Okay, so they will do a subcostal view and try to lay out the SVC and show you where it enters the atrium to look for anomalous veins. We hardly will get that, right? Sometimes we will, but oftentimes that's not one of the things that we'll get. So just want to remind you that it's not all just ostium secundum ASDs. The really rare one here is this unroofed coronary sinus type ASD. Okay, what is that? Okay, so the coronary sinus basically is the venous freeway that is draining your cardiac venous return back to the right atrium. Okay, and persistent left superior vena cava, you're going to run into that, right? And that's not really considered a major anomaly. Who cares if you have a persistent left FCC, unless you need a pacemaker, it usually doesn't matter much, okay? However, in rare cases, the roof of that coronary sinus between it and the floor of the left atrium is missing and there's a hole there. And so this highly deoxygenated venous blood will actually enter the left atrium and the patient will be desaturated. And those patients often have persistent left SVCs. So if you have a patient that you're seeing and they're just satting like 94, 95%, their hemoglobin levels high, you know, why are they erythrocytotic? You know, they desaturate with exercise. Oh, maybe they have a PFO. So you do a right upper extremity injection and the bubble study is negative. Okay, well, no, then there's no atrial level shunt. Well, actually, it's in that kind of patient where you should think about this kind of unusual situation and actually do an injection, a bubble study. I generally encourage people, if you're going to get a bubble study, get it from the left, right? Because if you have a persistent left SVC, it's going to show up. If you have a persistent left SVC with an unroofed coronary sinus, it's going to show up and bubbles will enter the left atrium before they even get to the right atrium. And then at that point, you're going to say to yourself, wait a minute, something is connecting from this venous return directly to the left atrium or to a pulmonary vein. And then you're going to figure it out, right? And it's an unusual kind of thing to run into. But again, you know, listen, what we specialize in is the rare and unusual. So basically, I'm just going to show you unusual things that you should be at least alert to, okay? Let's keep going. Guidelines for ASD closure. Why are hemodynamics important? Why are hemodynamics important? Because if you just follow the 2018 guidelines, okay, and we're going to have new guidelines coming up 2025, which is why I have to leave a little bit early today, because we're going to go and talk about those guidelines and exactly what we're going to say for those guidelines. And I don't expect major changes outside of this, right? You got to do hemodynamics. So even in a left to right shunt, that patient should have an assessment of the degree of pulmonary hypertension, what their pulmonary arterial resistance is, and what their QP to QS is. And maybe some point will arrive where that can all be done non-invasively and really accurately. But at this point, you know, it's still a major part of guideline recommended management of these patients. And then if you add to that functional impairment, then it's a class 1 indication for either surgical or transcatheter closure. Okay, if they don't have functional impairment, then it's a 2A. So, you know, you should probably still do it, but it's not as high of a recommendation. This middle section here, the people who have an elevated pulmonary arterial resistance and some degree of pulmonary hypertension, but are not cyanotic, are not shunting exclusively right to left or mostly right to left across the septum, those are the tricky ones, because those are the ones where they may benefit from closure in certain circumstances, but really you have to individualize that care a lot. And you really need to involve your PhD. Here at UCLA, honestly, we're lucky. We've got a great PH program, and they work very closely with us, hand in glove, and it's been awesome. Our patients have benefited immensely from that relationship. And I would say to you that, you know, regardless what kind of cardiology you're doing, you should have a good relationship with your PH specialist or be a PH specialist, and then you can have a good relationship with yourself. If you have a right to left shunt and a patient is cyanotic with an ASD, so a patient comes in, they have an ASD, their saturation is 88%, and by echo, they have evidence of severe pulmonary hypertension, and by exam, they have evidence of severe pulmonary hypertension, do not send that patient for ASD closure. And if you are a future interventionalist, please do not close this ASD. You are going to get into major medical legal trouble if you do, because in guidelines, by the way, they have class 1, class 2A, class 2B. Class 3, basically don't do it, it's useless, and then they have class 3 harm. If a guideline says class 3 harm, it means not only should you not do it, but if you do it, it is known to actually harm the patient. Okay, so that's where, what are guidelines really, right? Guidelines are standards of care. That in medical legally, guidelines are utilized oftentimes as the sort of standard of care that you should have met. So know these guidelines and know that with severe PH, you do not want to close ASDs. What happens with age when we're dealing with ASDs? Because, you know, in the end, your ASD when you're a child is very dishomogeneous. Sees a 3-year-old with an ASD. Is that the same kind of patient as a 55-year-old with an ASD? They both have an ASD, right? No, not whatsoever. Because what happens with age is you develop a couple of problems, okay? One is you're going to develop LV diastolic dysfunction, right? Your LV is going to get stiffer. And so as your LV gets stiffer, remember, shunting across the atrial septum is driven by the diastolic tone of both ventricles. So if your LV diastolic pressure, filling pressure is higher than your RV filling pressure, you're going to shunt left to right. If you're a 55-year-old who's now developed hypertension and you're diabetic and you've got coronary disease and so on, then your risk that you're going to be shunting more goes up. And that actually now becomes really important because if you just go and you close that ASD in that patient without taking that into consideration at all, now you're taking this LV that's been underfilled for 5 decades or 6 decades or whatever, right? And on top of it, you're now doubling the filling volume of that LV, right? So now if you're starting with an LVEDP of 14, 15 at baseline, your LVEDP is going to be 25 when you close that ASD. And that patient of yours is going to wake up and go, what'd you do to me? I can't breathe. I have pulmonary edema now. So that's something we need to take into consideration as these patients age. This is just a estimation of QPQS based on ASD size. And the takeaway point here is that your QP to QS ratio in general is going to be less than 1.5 to 1 if your ASD is less than about a centimeter. Okay. So I just made a big statement here, which is false very often. Okay. Why? Because if that patient is 65 years old and has a lot of LV diastolic dysfunction, then they may have an 8 millimeter ASD with a QP to QS ratio of 1.8 to 1. And then therefore, it's not as simple as just the size of the ASD. So I'm going to tell you guys stuff, and then what I'm going to do is I'm going to then tell you why what I just said wasn't like, you know what I mean? So this is the nuance, right? It's not just the size of the hole, it's the relative diastolic tone, right? And so with age, you're going to expect that to worsen. How about, you know, what happens if you close ASDs in older patients, right? You can close ASDs. We shouldn't be ageist. You can close ASDs, but don't expect that you're going to get the same degree of RV remodeling in a much older patient or reversal of pulmonary hypertension as you do in a younger patient. So I'll just go to, this is just what ends up happening when you do it. Generally, their cardiopulmonary exercise capacity will improve. The LV will get bigger, which makes sense because now you're filling the LV more. The RV will get smaller, which also makes sense because you're filling the RV less. And your CO2 max will generally improve in these patients. So it's good to close ASDs, right? But this particular study out of Germany here took 236 patients, adult patients undergoing ASD closure. And what they did is they broke them down into various ages, those less than 40, those that are 40 to 60, and those that are greater than 60 years of age. So clearly you can tell the green line here, if you're less than 40, you are going to basically remodel that RV big time, and the RV will essentially normalize in size. Less so if you're 40 to 60, but if you're 60 years of age, that RV size is not going to completely normalize. So you want to basically try to catch these earlier in life, less than 40 years of age, try to close them then before you have this adverse remodeling. How about your pulmonary artery pressures? They'll get a lot better in younger patients, but in older patients, don't expect that you're going to resolve your pulmonary hypertension completely. You won't, and you'll continue. So this is where, in just speaking with patients, what you want to do is you want to basically, have them understand, and have appropriate expectations of what they're going to get with this. Because then people get really upset. Well, why is my right ventricle still enlarged? Okay, why do I still have some shortness of breath here? Why are you still detecting some degree of pulmonary hypertension? This is what's expected. NYHA functional class also in older patients, right? More of them are going to stay class 2 and even class 3. So, and that may be in part also contributed to by the stiffness of the left ventricle, right? So all of that stuff to think about. And then early on, when you close the ASD, expect that in the first couple of weeks, if you check your BNP level, it's going to shoot up. Why? You're filling the LV more, and the LV is stiff. But if you wait on that, and you bring them back late, 6 months later, then it'll go back down. So that LV will remodel. And there's various ways that people have addressed this issue. Like, in Canada and Toronto, my buddy Eric Horlick, who does a ton of these, what he does is he puts older patients on diuretics a few weeks before he does the ASD closure. And so he basically is like, you know what, man, I dry them out before they come in. And then I don't have to fenestrate the device or anything like that. That's how I do it. Others will actually admit these patients into the hospital and even put them in the CCU on milrinone and IV Lasix for a few days while they diurese, and then their LV compliance improves a little bit. Milrinone's a bit of a lusitrope, right? And you're bringing down their filling pressures, and then put them on oral Lasix and send them out. I actually have a little bit of a different approach, and that what I do with these is I actually fenestrate the device. This is just AFib risk, and again, just saying that if you are younger, you're less likely to have AFib after ASD closure than if you're older. The same stands for tricuspid regurgitation. Okay, so now I'm going to show you some examples of cases. And this is where, one can imagine, like, if you're not, if you don't like really detailed work and spending a lot of time looking at hemodynamics, congenital cath is probably not your game, because look at this, right? This is a 38-year-old with an ASD and severe PH, and this is done in a much earlier era. I think this is a patient of Dr. Shapiro's that I maybe did 15 or 18 years ago now. But what we do is multiple phases of the cardiac catheterization. Baseline on room air, condition 1 on inhaled nitric oxide, condition 2, balloon occlusion of the ASD, and then condition 3, post-device deployment, and this is a fenestrated device. How does it look? This is very busy here, okay? These are called Valentines, and we have a program for congenital cath that's called Peds Cath that allows us to basically put in figures, and then we can, plop the numbers into these figures so they make sense. This is just an ASD, but now imagine, I'm giving you a really complex dextrocardia, upstairs, downstairs, ventricular inversion. If I just describe it in words, it's really hard to know, like, what is this guy saying? So we do this visually, okay? And then what I've tried to do for you guys here is I've just taken these numbers and just used an Excel graph here to just graph them out for you. This is QP to QS, and this is pulmonary arterial resistance. So at baseline, your QP to QS ratio is less than 1. Okay, so this would be one of those according to the guidelines. Don't touch it, okay? Your pulmonary arterial resistance at baseline is almost 8 Woods units. So also, according to current guidelines, you would not touch this. Then we put the patient on inhaled nitric oxide, pulmonary vasodilator. And lo and behold, what happens? The PVR goes up. I'm sorry, not the PVR. The QP to QS goes up, the PVR comes down. We then balloon occlude the defect, and things kind of go back to close to the way they were, but not as bad. And then I put in a fenestrated ASD device, and now I've left the patient with a little bit of a higher QP to QS ratio, but the PVR is lower because now I put them on pulmonary vasodilators. So I hardly do this anymore, but this is an example of if you were going to close somebody with severe pulmonary hypertension, this is how you should do it. Okay, multiple phases and eventual fenestrated closure. and then treating with PAH medications. This is a lady with LV diastolic dysfunction. And this is the one that I was kind of just giving you the example of with the stiff LV. Okay, again, let's look here what's happening. QP to QS ratio at baseline is a little above 1.6 to 1. Pulmonary wedge pressure measured simultaneously at that time is about 16. I balloon occlude the defect. QP to QS ratio goes down to 1 to 1 because I closed the hole in the heart, so there's no more shunt. But look at the wedge pressure. The wedge pressure went up to over 35 millimeters mercury. So then I fenestrate the device, and now I leave the patient with a small ASD and a QPQS of 1.2 to 1, but the wedge pressure is now low at 15. And I'm not sure this is the same exact patient, but the example suffices here, which is balloon occluding the ASD here. Your wedge pressure in this particular patient is almost 30 with V waves into the 40s. I take the balloon down and the wedge pressure comes down to near normal. Okay? So a nice way to just test the compliance of your left atrium and your ventricle, left ventricle, and the ability for them to handle all the flow if we don't fenestrate the ASD. Okay, this is just fenestrated ASD closure. This is a lady with Epstein's anomaly of the tricuspid valve, also with an ASD, who's also pregnant, and she's cyanotic, and the baby isn't growing well. Okay, so now there's all this stuff. Okay, so what am I going to do here? So now I have to think about all kinds of stuff. I think she was about 18 weeks here, and there was basically intrauterine growth retardation, right? The SAT of the mother was down in the 80s. And so I want to improve the SAT. But I also have severe tricuspid regurgitation and a really stiff RV because she has Epstein's anomaly, okay? So I also don't want to put her in the right heart failure. And she's only 18 weeks into the pregnancy. So now I have to think about, if I do something now, what do hemodynamics do? What's going to happen as the pregnancy progresses and the cardiac output has to increase and the circulating blood volume is going to increase significantly? So how do I test for that in the cath lab? And this is where I'm going to quote Eric and I's old mentor, John Michael Criley, who used to basically beat into us when we were trainees. The cardiac cath lab is a laboratory. It is a laboratory. So it is the place where we can figure some of this stuff out. So what did I do with this patient? Well, what I did is I did baseline hemodynamics. Well, first of all, she's pregnant. So did I radiate her? Very little, okay? Almost no radiation. I really dumbed down the fluoro as much as possible. I protected the abdomen, went in from below, didn't use TEE, used intracardiac echo to guide pretty much everything that I did. And if I'm tapping on fluoro, it's like a 1 second tap. And actually, I found out during this procedure that you can get a great fetal ultrasound using intracardiac echo. It's amazing. I still included the pictures. It was like unbelievable because you're going up the femoral vein and you're literally right behind the uterus. Yeah. So that was a kind of a revelation. But then thereafter, we focused on the cardiac stuff. So what did we do with that? We said, okay, here are the baseline hemodynamics. Let me balloon occlude. You see how often I balloon occlude the defect? Let me balloon occlude the defect. Check out what happens to the SAT and the RA pressure. Well, what happened? The SAT got a lot better. Look at what happened to the RA pressure. It went from 8 to 12. So already I got a jump up in 4 millimeters mercury. Then I said, gosh, let me try to mimic what would happen later in pregnancy. So I gave her volume. I gave her like 500 cc's of normal saline. And then I gave her a little dobutamine. Okay. Just to get her a little bit tachycardic to see what would happen now if I did this later in pregnancy. And sure enough, I mimicked later in pregnancy. Sure enough, those pressures remained high, right? At 15 or so, or they went up even further to 15. Okay. So what did I do? I fenestrated the device and I basically made her SATs better. So now the SATs went up to 96%. The RA pressure went up by 1 millimeter mercury, and that was enough to help with the fetal growth and get her through the pregnancy. Okay. So again, using hemodynamics to come up with a very nuanced way to deal with a situation. Okay. And each case is an individual case. So this isn't just like, oh, there's some algorithm. This is the algorithm I always use. You kind of have to think out of the box a little bit for this. This is an interesting one. So, hey, you always want to relieve severe critical tricuspid stenosis, right? It's bad. Sure, it is bad. But here's one thing we found out, that actually if you implant a transcatheter valve and relieve severe tricuspid stenosis, guess what happens? All of a sudden, that underfilled heart, all this blood pours in, and you may not have had much in the way of pulmonary hypertension before, and now you've got severe pulmonary hypertension. And now the patient's going in and out of VT, and now the patient has pulmonary edema because the heart has been underfilled for decades because they've had severe tricuspid stenosis. So just realize when you do stuff, you guys, there are collateral effects that it can have that you should keep in mind and look at. So doing hemodynamics after you've done an intervention is also important to see where that plane actually landed. For a PDA, let me see how much time I have. Okay, I got a little more time. For a patent ductus arteriosus. So early on in life, these are going to shunt left to right. And we're talking here about large PDAs, okay? And so early on in life, your left ventricle is going to be big, your left atrium is going to be big. You leave that untreated and they develop pulmonary hypertension. Eventually, the pulmonary arterial resistance will either approximate or exceed the systemic arterial resistance, and they will start shunting right to left. But if they come into your clinic and you check their finger sat, you may find that it's 96%, 97%. So you have to look at their toes. And you have to check the toe sat. This may end up on your boards, guys. So this one, okay, just remember this is called differential cyanosis. Okay, so if you hear PDA, pulmonary hypertension, loud P2, Graham-Steele murmur of high pressure pulmonary regurgitation, which sounds very similar to the murmur of aortic regurgitation, right? High pressure PR is going to sound very much like AR. Then you got to look at their toes. If you see clubbing and cyanosis of their toes, then they have Eisenmenger syndrome with a PDA. And that is a PDA you should not close. You should leave that PDA alone. So this is an example of a PDA you can close. Okay, look, it's small. It's all left to right. It's filling the PA here. It's not so tiny that it's not deserving of closure, but you know, it's not a huge right to left shunt. And then I put in a device here. Okay, no problem. Okay, there's a device. There's no more PDA. Yay, done. Okay, that's easy when you don't have pulmonary hypertension. That's not a big deal. It's not easy, but it's not, you know, a life-threatening situation. This, on the other hand, is a life-threatening situation. Okay, so notice here what I'm doing is the catheter is in the PA. So I've injected the pulmonary artery, and look at the contrast is going through the PDA down the descending aorta. And then I'm checking simultaneous hemodynamics in the PA and the AO. And I colorize them for you guys so that make more sense. Blue blood, red blood. So you see how the PA pressure is higher than the aortic pressure in systole, but it's lower in diastole. What could explain it being a little bit lower in diastole? I mentioned it just a little while ago, pulmonary regurgitation. Okay, so if you have high pressure PR, you're now going to be decompressing that pulmonary arterial circuit a little bit. Okay, but this is the kind of case where early on in my career, I used to kind of flirt with the idea of can we treat and potentially close these? And what I would do with these is I would go in and I would, just the way I balloon occlude the ASVs, I would balloon occlude the PDA to see what happens to the relative pressures and all that. And in some cases where there's a big left to right shunt, significant left to right shunt, the PA pressure will come down. But in other cases, like in this case, the PA pressure shot way up, the aortic pressure plummeted, and the patient nearly coded on the day. And actually, as a matter of fact, now in pulmonary hypertension, you guys, what we're doing is looking at creating PDAs as pop-offs for patients with severe PH. Transcatheter creation of a patent ductus arteriosus by placement of a covered stent or a fenestrated device between the pulmonary artery and the aorta. So, game's changing. Vasoreactivity in patients with Eisenmenger syndrome. Why does it matter? Does it matter? Should I even do it? Who cares? They already have severe pulmonary hypertension. Well, it actually does matter, and this is showing that a patient has some vasoreactivity. And the reason it matters is really this graph here and this here, which if you have vasoreactivity, your event-free survival is far better than if you have no vasoreactivity whatsoever. So if you want to prognosticate about what could happen with your patient, you should do vasoreactivity testing. Now, even if they don't have vasoreactivity, we're still giving them pulmonary vasodilators, okay? That has been shown to actually improve outcomes in these patients, functional outcomes, as well as actual hard clinical outcomes as well. So we are treating them with that. And this is the new kid on the block. And this is a case that we just had in the last few weeks that I thought was absolutely outstanding. Okay, and this is cardiopulmonary exercise testing and measuring invasive hemodynamics. Okay, since the coming of a guy named Rich Chanik here to UCLA, okay, Rich has, and we should be very thankful to Dr. Chanik and to UCLA for supporting this, right? What they did in Cath Lab 7 up there on the 7th floor is they put in a cardiopulmonary exercise system and a bicycle ergometer that's basically a reclining bicycle ergometer so that we can now do cardiopulmonary exercise testing with invasive hemodynamics. Okay, the wealth of information you're going to get from that is insane, you guys, especially if we can add echocardiography to it. Right, if we now can add echocardiography, I mean, gosh, like, you know, Eric and I could like be in there for days just playing around. You know, it's awesome. In this particular case, this was a 26-year-old who had a late VSD repair, has pulmonary hypertension, and also has a bioprosthetic aortic valve that's failed. Okay, the bioprosthetic aortic valve is Gengen Lurie's patient, is now severely regurgitant, and the guy comes in volume overloaded. Okay, and we were set to take this guy and have him either have TAVR or surgical aortic valve replacement. Okay, and then we got the PH team involved, and they ended up doing a cardiopulmonary exercise study on him with invasive hemodynamics. And I'm not including everything here outside of the following, okay? Right atrial pressure starts below 10 millimeters mercury. At 45 watts, gets up to maybe 16, 17 millimeters mercury. At 60 watts, and at this point, the patient's about to code, okay? At 60 watts, the RA pressure is 30 some millimeters mercury, okay? Now look at the cardiac output. Cardiac output starts at 5 liters per minute. You know, I should have put it on different scale because it actually did go down at 60 watts, but starts to drop at 60 watts, okay? But the PA sat, unbelievable here. Okay, it starts at almost 70% at 45 watts, drops to about 48%, and at 60 watts is down to 13%. Okay, so that patient, their problem in the left atrial pressure, the wedge pressure, as a matter of fact, I should have included it here, actually decreased with exercise. Okay, so is the problem aortic regurgitation? No, what's the problem here? What's the problem? Okay, say it out loud. Jump on the grenade, Shay. It's pH. It's pH. It's basically severe critical pulmonary hypertension is the problem in this patient, more so than a leaky aortic valve. So it changed everything that we did. Instead of actually going and doing a really high-risk aortic valve replacement or TAVR, okay, we ended up actually treating him more aggressively for pH, and now he is on the, or is going to be getting on that latest, the sotatercept, the latest pH therapy that they're going to use, and then we'll reassess about fixing his aortic valve. But yet another way that hemodynamic understanding completely changed what we would have done with the patient. That non-invasive assessment alone would not have helped us, right? Okay.
Jamil, was that just late sequelae from remodeling from the VSD? Is that what you think the PH?
Yeah, so, okay, great point, Eric, right? Should this guy's VSD have been closed?
Well, I don't know, or was it just remodeling that maybe just still continued to?
No, I think this guy had severe pulmonary hypertension. And this is one of those where if that VSD was closed, it wasn't closed here, but this is where if we were going to think about something like this, we would do a fenestrated VSD closure. So you'd end up leaving the small VSD that's restrictive as a pop-up for that RV, right? And that wasn't done in this particular case. But yeah, this kid had pulmonary hypertension that was bad 15 years ago or whenever this VSD was actually so yeah, something to keep in mind there. And then, okay, this is where it gets really complicated, but I'm not going to spend a lot of time on this. But those of you guys that come and rotate with us and see our Fontan patients. So oftentimes we're talking about closing fenestrations in Fontan patients to improve their oxygen saturation. Well, this is where actually, adjusting the steady state can play a major role. So in deciding whether you're going to do this or not. So we go in here, and for those that have rotated through ACH, we know that we don't want to close Fontan fenestrations in anybody with a Fontan pressure over about 16, okay? Or, now we've even gone down a little bit to 14. But you go with this patient and you go in, you go, okay, well, starting, it's just 16. So maybe I can close it. But okay, it's 16 in the presence of hypotension because they're under anesthesia and with a QP to QS ratio of only 0.5 to 1. So now if I actually close the fenestration, which is the ASD in a Fontan patient, now the QP to QS ratio is going to be closer to 1 to 1, and I'm going to end up with a much higher Fontan pressure. And as a matter of fact, this patient increased their Fontan pressures just with us giving them contrast. Right? So we did some angios and then we just remeasured pressures and said, whoa, we're not touching this fenestration. This patient actually needs a transplant versus this patient, right? We go in, we do the same thing. Fontan pressures look like they're 16 at baseline, but this is in the presence of ephemeral artery pressure, 69 over 38, okay? So QPQS is less than 0.7 to 1. We put them on a little bit of Levophed here, increased their MAP from 49 to 60. Fontan pressure jumped up to 20. So the point that I'm trying to make here is hemodynamic modulation in the cath lab is actually important, right? Not just steady state, but also if I volume load, if I make your heart rate faster, if I exercise you, I'm able to now look at these things and now the picture becomes clear. Like that PH patient that I showed you, right? If we had just done the diagnostic catheterization with that patient not exercising, we would not have arrived at the conclusion that we arrived at when we did the exercise cath. Okay, so I'll finish off. Conclusions. Diagnostic cardiac cath remains an important component of the care of adults with congenital heart disease. And I would just venture to say that in any cardiology patient, okay, understanding diagnostic cath and its role is really key. Just because we don't need to do it all the time anymore, it doesn't mean that it's a dead art that has no role whatsoever. And honestly, I really feel that during your basic cardiology training, it's absolutely key that this is something we should be giving you more lectures on, which is why I chose this lecture today. In the cath lab, we have the opportunity to evaluate baseline hemodynamics and assess changes with state alterations, right? It is a laboratory. Comprehensive diagnostic cath facilitates nuanced interventions based on individualized hemodynamic assessment. And this is really key, right? You want to use sexy terms, okay? It's personalized medicine. Okay, it can't get more personalized than this. Okay, actually looking at the nuanced adjustments of that specific patient in the cath lab to decide if this is the right option for you, not the herd medicine of this is just what we do. Cool? Modulation of hemodynamics by judicious use of volume loading. Okay, you got to be smart about this. Don't go pouring in 1.5 liters and then your patient now can't get extubated, right? A couple of 100 cc's and then watch what's happening in the hemodynamics as you're putting in the volume. Pharmacologic therapies. I showed you with that pregnant lady how dobutamine was very useful. Exercise testing, improves our understanding. In an age when cardiac cath has become predominantly an interventional domain, there remains an important and foundational role for diagnostic cardiac cath, and it's imperative that this and future generations of trainees receive adequate training in this area. I'll stop there and I'll take any questions. Thanks. Okay, doesn't look like we have any questions.
Jamil, this is Henry. Don't recognize you with the tie, but for the cyanotic Eisenmenger patients who undergo non-cardiac surgery, is it still the teaching that just E-line and an O2 sat is sufficient to monitor those patients?
Yeah, I don't think you need to put a PA line in those patients, Henry, but I would say that having a either a big peripheral IV that can take pressors if need be. Ideally, I would say getting an IJ line so you can actually look at CVP, look at your SVC sat, and give therapies through that as needed is key. And then an arterial line, a peripheral arterial line. And that I think would be just standard for these patients. And actually, thank you for asking about that population too, Henry. Please put bubble filters. I should have mentioned this to you guys. Any congenital patients that come in, just as a general rule, just say, okay, I'm going to put a bubble filter. Unless you definitely know there's no right to left shunt. Certainly if they're cyanotic, put bubble filters on so we're not injecting, bubbles and crud, and that's not going to the brain. But yeah, that's what we're doing now, Henry. Thanks for your question.
Jamil, yeah, fantastic talk. And again, to the fellows, really, and we're glad that we can have fellows earlier on in their training now to be exposed to you all. This is really one of the few places now where one of the last bastions of hemodynamic assessment, which is again critical. I would say for the non-congenital, bound fellows, thankfully, I think there is a little bit of kind of focus on, again, now with transcatheter intervention, that people sort of have to care about it now to do the right thing. But I think the bigger thing is, frankly, knowing good quality measurements is also just as critical. There's a lot of sloppy stuff out there, and really, Jamil's group really, will teach you how to make sure that these measurements are certainly high fidelity and accurate. I will annoy you with one AI-based question, because I know you say this is personalized care, but obviously, I think a lot of us are, especially for childhood ASHD survivors, kind of predicting the future of what the roadmap is for them. And I see here, given that ASHD is still a hemodynamic field, are there any systematic efforts to maybe put all this hemodynamic data into one big sort of system to kind of predict and look at, like, as people age and risk factors of how the hemodynamics will affect, long-term prediction of how people will do?
Yeah, there is. There's a colleague of ours, Gerhard Diller, who's in Munster in Germany. He's a good friend, and this guy has basically been the leader in AI in the congenital space, in the ACHD space, and he's actually looking at doing exactly that. And he already has AI-based algorithms that he's implementing for identification of pressure versus volume overload lesions for the RV. So I think there's going to be a role for sure. I mean, there's no question ACHD is going to have some degree of AI that is going to be helpful and predictive. But my worry there, as I think many of us are worried about, the loss of the art,
Sure.
Right? When you have, and I think, so what I would say is the two things are not mutually exclusive. You can use AI algorithms and prediction models, yet at the same time learn the art and the craft of diagnostic cardiac catheterization. And back to your issue about fidelity and the quality of the measurements and the quality of the caths, I keep bringing up Dr. Criley for a reason, because he was a huge influence on my life, and I think yours as well, Eric, right? And there was one quote from him. He had all these quotes, stuff that he used to say, but one thing that I repeat in the cath lab all the time, which is that anything that we're going to record has to be publication quality, right? Everything publication quality. So just make sure that whenever you're doing anything, if you are not willing to have everybody look at what you're doing and try to defend it when you're trying to publish it, it's not good enough. Go back and remeasure it, right? Get the bubbles out of the system so that there's enough fidelity. And I think if you do that, if you have your own internal controls, quality controls be that high, then you're going to end up doing real quality work. The impetus is not to do that, because you're not paid for that, right? It's not, you know what I mean? And it's an art that's being lost. So people just aren't really caring about it anymore. I'm just looking at the numbers. When's the last time you saw people looking at hemodynamic tracings, right? Maybe occasionally in cath conference, somebody does it. I saw Dr. Courier was on the Zoom here, and, I know he does it, right? Sorry, I didn't see who else was on, but this is something that I just really want your generation and, future generations to know that this is actually important. This is foundational for the field of cardiology. This is what got us to where we are. And we shouldn't just abandon it now because we have all of these other ways of, looking at it. And that's it in conclusion.
I agree. I think just coming back again to I totally agree that I think when these patients will end up in your hands is still obviously a personalized sort of management issue. I think one of the things, right, you guys struggle with is under detection of complications, right? The TETs, the people who have RVLT conduit failures, that a lot of people in the community don't recognize. The question is, could some of these algorithms in the future
Yes.
help trigger
Okay.
warnings and go, hey,
For
you
sure,
know what,
for sure.
RV's not looking right on MRI or TT.
No, I think you're right, Eric, and I think not only for people in the community, for us as well. For us as well. No, I listen, I'm all about loving on AI. That's not a problem. Like I am very much committed to doing everything I can to help us get those kinds of algorithms into place. That's great. That's great. But at the same time, the two are not mutually exclusive. So if you guys don't mind, I gotta run. Thank you so much. If anybody has further questions, just email me, okay? Thanks again. Thanks, Eric.
Yeah, thank you.